Welcome to the Funnel Effect.
It's great to be here.
Today, we are opening a file that feels less like a medical journal and more like a cold case investigation from the golden age of detective fiction.
That's a great way to put it.
But instead of a crime scene, we're looking at the human heart. We are analyzing the Eisenmenger Syndrome or pulmonary hypertension with reversed central shunt by Paul Wood, OBE, MD, FRCP.
A true classic. This was published in the British Medical Journal, London, on Saturday, September 20th, 1958. And this paper is, it's a masterclass in clinical observation.
It really is. So let's set the scene. It's 1958. Cardiology is in this explosive era of discovery.
It's a golden age.
Exactly. Surgeons are just starting to think about actually fixing hearts. Diagnostics are getting better. But there's this massive conflict brewing over one specific term, Eisenmenger's complex.
Right. And by 1958, that term was, it was basically on death row. The medical community was arguing that it was outdated, that it was confusing.
That it was useless?
Pretty much. That it should be just scrapped from the textbooks. They felt it was just a fancy, unnecessary label for a specific type of hole in the heart.
And then in walks Paul Wood. And for those who don't know, Paul Wood was a titan. He wasn't just a doctor. He was arguably the preeminent cardiologist of his time.
Oh, absolutely.
And he steps into this debate and basically says, hang on, not so fast. You aren't deleting this name. You're using it wrong.
Exactly. His mission wasn't to save a name for, tradition's sake. He wanted to fundamentally shift how doctors understood the entire disease process.
Oh, so.
He wanted to move the profession from looking at anatomy, literally just where the holes are and what the heart looks like, to understanding physiology.
How it works.
How it actually works, the pressures, the resistance, the forces inside the chest.
And that distinction, anatomy versus physiology, that's really going to be the theme of this whole deep dive, isn't it?
It's the entire story.
Okay, so before we get into Wood's big defense, let's define the mystery. What is the core condition here? What's actually happening inside the patient?
The core problem is a situation where the blood in the heart flows. Well, it flows backwards.
Backwards.
Yes. So normally, your heart has two sides, right? The left side is the powerhouse, pumps oxygenated blood to the body at high pressure. The right side is the low pressure side. It gently pushes blood to the lungs to get oxygen. So the flow is left to right to lungs.
Okay.
But in this condition, something catastrophic happens. The pressure in the lungs gets so incredibly high that it matches or even exceeds the body's pressure.
So the lungs become like a wall.
Precisely. A high-resistance barrier. The blood, trying to leave the right side of the heart, just hits that wall of pressure in the lungs and says, nope. It takes the path of least resistance.
Through a hole in the heart.
Through a hole, right back to the left side, bypassing the lungs completely.
Which means the blood never gets oxygen.
Correct. And that's what leads to the Harmark sign. Cyanosis. The patient turns blue.
Okay, so that's the stake in the ground. But to understand why Wood had to write this massive defense in 1958, we have to go back even further. We need to talk about the man himself, Dr. Victor Eisenmenger.
Right, so let's jump back to 1897. Dr. Eisenmenger publishes this paper describing one very specific patient. And the profile of this patient is fascinating because it just defies what you'd expect.
You'd expect someone very frail, very sick.
Exactly. You'd expect an invalid, especially back then. But Eisenmenger's patient was a 32-year-old man. He was described as powerfully built. He was active.
But he was blue.
Oh, yeah, deeply cyanotic. He'd been blue and breathless since he was an infant.
Yeah.
But somehow his heart had compensated. He lived a pretty full life until he was about 32, when things took a sudden turn.
What happened?
He developed edema, severe swelling signs of heart failure, and then he died suddenly after a massive hemoptysis.
Coughing up blood.
A lot of blood. Now, when they did the autopsy, or the necropsy, as Wood calls it, they found a large hole between the pumping chambers of the heart, the VSD.
A ventricular septal defect.
Right. But they also found something else, something that confused everyone for the next 50 years.
The famous overwriting aorta.
This is the red herring of the story. The aorta, the big artery carrying blood to the body, wasn't sitting where it should. It was shifted over, sitting right on top of that hole.
So for 50 years, the smartest people in the field, we're talking Maud Abbott, Helen Taussig, they looked at that anatomy and thought, the patient is blue because the aorta is physically sucking blood from the wrong side.
They thought it was a plumbing problem, an alignment issue. They figured because the pipe is over the right ventricle, It must be draining deoxygenated blood. It was all about the anatomy.
Which brings us right back to that controversy in 1958. Why were people so keen to get rid of the name Eisenmenger?
Well, by the late 50s, the critics just felt it was a confusing name for a VSD with high lung pressure. They argued, why give it a special name? It's just a hole. Let's call VSD a VSD and be done with it.
But Wood steps in and says, no, you are all missing the entire point.
He does. He argues that the position of the aorta, that overriding feature, is completely irrelevant, a visual trick. Wood says the real issue isn't where the aorta sits, or even where the hole is. The real issue is the pulmonary hypertension,
The pressure in the lungs.
the high pulmonary vascular resistance. So Wood creates a totally new definition. He says Eisenmenger syndrome isn't a specific anatomical defect. It is a physiological state.
And he puts a number on it, which I love.
He does. He specifies a resistance of over 800 dynes per second per centimeter to the fifth power.
800 dynes, it's so concrete. It's not just high pressure, it's a specific threshold you have to cross.
It gives you a diagnostic cutoff. And he also says there has to be a reversed, or at least bidirectional, shunt. So Wood is saying, I don't care if the hole is in the top chambers, the bottom chambers, or between the arteries. If your lung pressure is over 800 dynes and the blood is flowing backward, you have Eisenmenger syndrome.
He totally redefined it. He showed that this physiology could happen with any large defect, not just the specific one Eisenmenger saw in 1897.
Exactly. It's like, think of the lungs as a garden hose. If the hose is kinked, that's the high resistance. The pressure builds up back at the faucet.
And if there's a leak in the faucet somewhere.
The water's going to spray out of the leak. That's the shunt. The heart pushes blood. It hits that wall of pressure in the lungs, and the blood just says, I can't go that way, and it turns, goes through the hole, and back out to the body without oxygen.
So Wood didn't just have a theory. He brought the data. He analyzed a massive series of his own cases, 127 cases over 11 years.
Which is a huge sample size for a single clinician in the 50s. It's remarkable. And this is where he starts to classify things, breaking those cases down into three main groups based on where the hole is.
Okay, walk us through the three main suspects.
First, you have the paterductus arteriosus, or PDA. That's a connection between the main arteries leaving the heart.
Okay.
Second, the ventricular septal defect, VSD. That's the hole between the lower pumping chambers. And third, the atrial septal defect, ASD, which is a hole between the upper receiving chambers.
But here's a really crucial point he makes. Size matters. You can have these holes and not have Eisenmenger syndrome.
Oh, absolutely critical. Not every hole causes this. They have to be large. Wood coins this critical size concept. For a VSD to cause this, it generally needs to be, 1.5 to 3 centimeters across.
That's huge. That's like the size of a coin inside your heart.
It's massive. And the physics are key here. If the hole is that big, the pressures between the chambers just equalize immediately. The heart becomes functionally one big pump instead of two separate systems.
A small hole, you can maintain a pressure difference. A big hole.
The pressures lock together.
Okay, now this is where we get into what feels like the detective's notebook section. Wood breaks down the demographics, and he finds this really strange anomaly when it comes to gender.
This is one of the most fascinating parts of the paper, and it hints at biology we still don't fully understand today. When Wood looked at his PDA and VSD patients, the sex distribution was, pretty even, maybe a slight male lean.
But the ASD group was different.
Totally different. When he looked at the atrial septal defect cases, the hole in the top chambers, he found a massive female bias. The vast majority were women.
Why? I mean, why would women be more prone to this specific type of high pressure?
Wood suggests it might be linked to another condition called primary pulmonary hypertension, which also mostly affects women. It suggests there's something different about the mechanism. Maybe a hormonal sensitivity or something in the vessel walls that makes them more prone to this reaction.
And that ties into the time bomb aspect, right? Because the age of onset is completely different for these groups, too.
It is a stark difference. If you have a large VSD or a PDA, the high pressure is usually there from birth. The baby is born, and the lung resistance just never drops the way it's supposed to. They are Eisenmenger patients from infancy.
They're blue babies.
Right. But the ASD group, that's the mystery. These patients are often completely normal in childhood. They run, they play, they have pink skin, their lungs are working just fine.
And then what?
And then, usually in their 30s, the trap springs. Wood's data shows that 92% of ASD Eisenmenger cases start in adult life. The average age of onset is 35 plus.
That's terrifying. You live 3 decades thinking you're healthy, maybe you just get a little tired sometimes, and then suddenly you turn blue.
It's an acquired reaction. The lung vessels slowly, silently thicken and clamp down over decades until they hit that tipping point, that 800 dynes. Then the shunt reverses.
Let's talk about what these patients look like. We mentioned cyanosis, the blue skin, but Wood described something called differential cyanosis in the PDA patients. This just blew my mind.
It is a beautiful example of plumbing logic. You have to picture the anatomy. In a PDA, the connection is between the pulmonary artery and the aorta, but, this is the key, that connection is after the arteries branch off to the head and the arms.
So the blood comes out of the heart, goes to the brain, goes to the right arm.
And that's all normal oxygenated blood from the left ventricle, so the head and the right hand are pink.
But then the blood travels further down the aorta.
And it passes the shunt. At that point, the unoxygenated blue blood from the pulmonary artery gets dumped into the aorta, so everything below that point gets mixed, blue blood.
So you can have a patient with a pink face and pink hands, but blue feet.
Exactly. Pink hands, blue feet. A literal split in the body's oxygen supply. Wood even notes that sometimes the left hand is an intermediate color, depending on the anatomy.
Yeah.
But yeah, you see pink hands and blue toes. It's a PDA with a reverse shunt. It's diagnostic.
He also mentions clubbing, the thickening of the fingers and toes, and squatting. I've heard of this in blue babies, but Wood actually breaks it down by the type of defect.
Right. Squatting is this fascinating compensatory mechanism. When you squat, you kink the arteries in your legs. This raises your systemic blood pressure.
And why does that help?
It increases the resistance on the body side, which helps force just a little bit more blood into the lungs. It reduces the right to left shunt. Wood found this was pretty common in VSD patients, about 15%, but very rare in the ASD or PDA groups. It's another clue.
Okay, we have to talk about the symptoms. Breathlessness is obvious. But the big one, the really scary one, is hemoptysis, coughing up blood.
This is the red flag.
Oh.
And Wood's statistics here are they're grim. He states that hemoptysis occurs in 100% of patients by age 40.
100%. That's an absolute certainty in his data.
It is. It's never seen before age 24 in his series, but after that, it becomes inevitable. And these aren't just little streaks of blood. These are often massive events.
And it's a major cause of death.
Right. It's the immediate cause of death in 29% of the fatal cases. And Wood explains the mechanism so clearly. It's not just a vessel bursting from high pressure like a pipe bursting.
What is it then?
It's usually a pulmonary infarction caused by thrombosis.
Lots.
Yes. The blood flow in these high-pressure lung vessels is sluggish, it's turbulent, the vessels are damaged, clots form. The lung tissue dies, that's the infarction, and then you hemorrhage from that dead tissue.
And he explains exactly how the patient dies from this. It's not just that they bleed out in terms of volume.
Right, it's a physiological cascade.
Okay.
You lose a sudden volume of blood. This triggers what's called a vasovagal reaction, basically a severe faint. Your blood pressure crashes.
Now, in a normal person, you faint, you fall down, blood goes back to your head, and you wake up.
Correct. But in an Eisenmenger patient, their heart relies on that high systemic pressure to force blood into its own arteries, the coronary arteries. When the pressure suddenly drops, the oxygen supply to the heart muscle fails. The heart stops. They collapse and die within minutes.
That's a total systemic crash.
Exactly. A sudden, catastrophic loss of equilibrium.
So moving to diagnosis in 1958, no echocardiograms. They relied on ECGs, X-rays, and listening with a stethoscope. And there's this incredible paradox Wood talks about with the heart murmur.
This is the aha moment for every medical student. Normally, a VSD, a hole in the heart, has a loud whooshing murmur, one of the loudest sounds in cardiology.
Right, like putting your thumb over a garden hose.
Perfect analogy. It's the turbulence of high-pressure blood spraying into a low-pressure chamber. But in Eisenmenger Syndrome, remember what's happened. The pressure in the lungs has risen to match the pressure in the body. The pressures in the two chambers are equal.
No spray.
No spray, no pressure difference, no turbulence, and therefore, no murmur. The heart goes quiet.
That is so counterintuitive. The sicker you get, the quieter your heart gets.
And Wood emphasizes this. The silence is actually a sign of severe end-stage disease. The missing murmur is a grave sign.
That's chilling. The silence is worse than the noise.
In its place, you might hear a pulmonary ejection click. It's a sharp sound, heard in about 2/3 of cases, and it's the sound of that huge, dilated pulmonary artery snapping open under all that tension.
Let's look at the X-rays. Wood calls them skiograms, which is just a great word. What are we seeing there?
You see a phenomenon called pruning.
Like in a garden.
Very similar concept. The central arteries, the main trunks coming out of the heart, are massive. They're dilated from the pressure. But if you look at the outer edges of the lungs, the periphery, they look empty.
Oligemia, he calls it.
Yes. The small vessels have clamped shut to protect the delicate lung tissue, so you get this big, busy center and these ghostly, empty edges, a very distinct pattern.
Now, Wood spends a lot of time debating why the resistance is so high. Is it a spasm? Are the vessels just cramping? Or are they physically blocked?
This is the million-dollar question back then, and the implications are huge. If it's a spasm, maybe you can relax it with drugs. If it's a blockage...
Drugs won't work.
Right. So he tests this. He injects strong vasodilators, like acetylcholine and priscaline, directly into the pulmonary artery.
These should force the vessels to relax.
They should. And the result? Usually, almost nothing happens. The pressure barely drops.
What did that tell him?
It proved to Wood that the vessels were physically altered. They were thickened, obliterated, blocked by scar tissue and muscle. It wasn't just a cramp. The door wasn't just closed. It was bricked up.
He also does this Valsalva maneuver test. That's where you bear down, right?
Right. When you do that, your blood pressure fluctuates in a specific pattern. And Wood showed that in these patients, the systemic blood pressure and the pulmonary blood pressure tracked each other perfectly. They moved in lockstep.
Which proves what?
It proves that the two systems were functionally locked together by that big hole. They weren't independent anymore. The high pressure in the lungs was inextricably tied to the body's pressure.
So let's zoom out a bit. We've got these three main groups, PDA, VSD, ASD. Wood gives us a kind of cheat sheet to tell them apart, even without modern tech. Can we recap that?
Absolutely. Here's the Paul Wood algorithm. Number 1, you see a patient with pink hands and blue feet.
That's PDA.
It's PDA, no question. Number 2, the history goes back to infancy. The patient squats to breathe, and it's a male.
Probably a VSD.
Very likely a VSD. And number 3, the patient was healthy until their 30s, is female, and on an X-ray has a gigantic right pulmonary artery.
That's the ASD.
That's your ASD.
It's amazing how he breaks it down so logically. But then we get to the prognosis, and this is the tough part. What was the future for these patients in 1958?
In 1958, it was grim. Most patients would succumb to heart failure or that massive hemoptysis in their 30s or 50s. It's a significantly shortened life.
And the natural question is, can't we just do surgery, just sew up the hole?
And Wood is very, very explicit about this. He calls surgical intervention ill-advised. He warns against it.
Why? It seems so logical. There's a hole. You fix the hole.
You have to go back to the physiology.
Yes.
The lungs are a solid wall of high resistance. The right side of the heart is just not strong enough to push blood through that wall.
Yeah.
That hole is currently acting as a safety valve.
It's letting the pressure escape.
Exactly. It allows the blood to escape over to the left side. Yes, that blood is unoxygenated, so the patient is blue. But it is better to circulate blue blood than to pump against a solid wall and have the heart fail immediately.
So if you close the hole?
If you close the hole, you remove the safety valve. The right ventricle tries to push against that massive lung pressure. It can't, it fails, and the patient dies of acute right heart failure, often right there on the operating table.
The hole is actually what's keeping them alive.
In a tragic irony, yes. The defect that caused the problem becomes the only thing sustaining life.
That just drives home the whole point of the paper, doesn't it? Understanding the physiology was so much more important than just the anatomy.
It was everything. If you just looked at the anatomy, you'd say fix the hole. If you understood the physiology, you'd say leave it alone. Paul Wood likely saved countless lives simply by telling surgeons to put down the scalpel.
So as we wrap this up, what is the big takeaway? Wood saved the name Eisenmenger, but he completely changed what it meant.
He did. He moved cardiology from a discipline of looking at structures to a discipline of understanding resistance and flow. He taught us that Eisenmenger syndrome isn't a specific birth defect. It's a destination. It's the end-stage result of any large connection that's left untreated. It's a situation where the lung pressure wins.
And it leaves us with this lingering mystery, doesn't it? Specifically about the atrial septal defect.
It really does. Wood clearly states that in ASD, the high pressure is acquired late in life. But he doesn't fully answer why. Why does a woman with an ASD live perfectly fine until she's 35, and then suddenly her lung vessels start to thicken and close off? What pulls that trigger?
If we could find that trigger, that specific biological switch that flips in the 30s or 40s, could we prevent it?
That is the question, isn't it? The paper leaves the trigger for the onset of hypertension in ASD as a lingering mystery of vascular biology.
A mystery for another deep dive, perhaps.
Yes, indeed.
Thank you for watching The Funnel Effect.